So with that quick introduction, I want to talk about how to do a primary care psychiatry interview. How do you do this in a busy primary care setting? I'm going to ask the group here, on average, how much time do you have with a patient? A follow-up patient. Just shout out, how much time? 10 minutes? 15? 20? Can you guys hear me okay, by the way? Testing. Okay, good. I like to roam a little bit, by the way. So 10, 15, 20 minutes, right? Do anyone have an hour? Oh, psychiatrists have an hour. Does anyone have a couch in there? I'm just kidding. So here's the thing, right? The approach that we're going to take here is really focusing on a busy practice. And we know, our faculty know, and I want to emphasize this, we are fully aware of the fact that all of you are so busy. So when we're teaching something and you feel inclined to say, hey, I don't have time for that, or that's a Pandora's box. I can't make my patient cry and ask them how they're feeling. Oh my goodness, right? Because you were thinking that, weren't you? I can see it in your eyes. What we're doing is we're focusing on the limited amount of time that you have. Okay, so please know that as we go forward, we're not going to be asking you to do stuff that you just don't have time for. This is a textbook here that our fellows are receiving. It's kind of the core curriculum for the course, and many of the slides that we have correspond to this as well. But it is a good review, particularly when you're in your mentorship sessions. Today, I want to talk a little bit about sort of the foundation, the goal of how we do a primary care psychiatry interview using the AMPS mnemonic, AMPS, right? And so looking at anxiety, mood disorders, psychotic disorders, and substance use disorders. Now, I'm not going to give a whole lot of detail on the treatment of these disorders, but I do want to take some time and go over with you what we think are best approaches to how to ask these questions in a busy primary care setting. That's the goal here, if that makes sense. Talk just a tiny bit on personality disorders and suicide risk assessment. But I want to start out with a case, right, of a 26-year-old guy with history of, as he says, social drinking. I got it under control. It's just social, doc, right? And brought in by his wife, primary care doc, with concerns of sadness, restlessness, bad thoughts that are fast, by the way. And he really can't sleep very well. He has initial and middle insomnia with headaches for the last couple months. And that's why he's coming in to see you, because of headaches. Problems with depression in the past, no past admissions. So just real quick, what are some initial thoughts or concerns that you might have with this particular patient? Say it again? So alcohol might be an issue, yeah, certainly. What else? Depression, yeah. Possible bipolar, yeah. So if you give someone like this an antidepressant, right, that might not be so good, right? And so sometimes we might do that, right? And say, well, gosh, you're feeling down, you're depressed. Let's give you an SNRI. That'll help with your headache too. But what's likely to happen if the patient has bipolar disorder, and by the way, we're going to talk about how to make that diagnosis pretty quick. But if someone has bipolar disorder, what's likely to happen if we give them an antidepressant that's unopposed is they're not likely to get really manic all of a sudden, but they're more likely to not get better. And they're more likely to get a little worse when it comes to irritability and anxiety. And so we'll talk a little bit about that. And then later in the day, Dr. DeMartini is going to be talking to us about how do you treat bipolar in a busy primary care setting. So what I'd like for you to do is if you could just take your phone out, and we're going to be using Poll Everywhere. So if you can text 37607 just on your phone, that'd be great. And then you just text, and then you just put in the message line TNT PCP. By the way, how'd you guys like that AC/DC video? Wasn't that kind of cool? It was kind of neat. It's like a jolt, right? Jeff, thanks for doing that. I appreciate it. That was really awesome. So 37607 is the number, and then you want to message TNT PCP. Okay. So here's a question I have for you, and I think most of you are going to get this right, because if we're able to see it, that is. Let's see here if we can try this again. Maybe you won't get it right, actually, because you can't really see it. So, but here's the question that I had is, how do you screen, and we're going to use Poll Everywhere for the rest of the weekend, but how do you screen for depression? So how do you guys screen for depression? You're pretty busy. I know you use the PHQ-2 and the PHQ-9 in your settings, but when you're talking to a patient, what do you ask? And it's important. This is important. Why? This is important because depression is the #1 cause of disability worldwide, right? And depression happens. It's very common. So how do you, is there a couple questions you ask? What do you ask if you want to know if someone's depressed and you're kind of screening for it? Or do you screen for depression? So yeah, how long have you been feeling depressed, right? There's a lot of questions you can ask. And we're going to go into that. But really we want to kind of really nail it down and use this particular slide here. This is probably, for at least my talk, probably one of the most important slides that I want to go through, because we want to use this slide as a bridge to help all of you figure out, how do I ask these questions? If you ask these questions, you'll cover about 80% of what you need to cover in a busy primary care visit when there's a behavioral health care issue. Now, if there's eating disorders involved, that's not on here, right? If there's sleep disorders, which many of our patients have, that's not on here. But this is a quick, non-comprehensive approach that we can ask using the AMPS mnemonic, right? And so this is something that we're going to be using going forward. Let's start with the A in AMPS, right, in anxiety. Why would we want to ask patients about anxiety? What's the reason? Why would we want to ask about anxiety? Anyone? What's the reason? Yeah. So depression and anxiety come together, true. And depression and anxiety are often comorbid with fibromyalgia, irritable pain syndrome, pelvic floor dysfunction, the list goes on, insomnia, right? But why else would we want to ask about anxiety? We don't ask about pheochromocytoma, right, with our patients very often. Say it again? Quality of life, yeah. But why else? Has anyone in the room experienced anxiety before? Yeah, that's the reason why. So it's common. So common things happen commonly. Asking your patients about anxiety is critically important. And how do you ask them about anxiety? Our recommendation is just to do that. Hey, is anxiety or nervousness a problem for you? I like to throw in the nervousness because some people may not connect anxiety with anxiety, right? And so nervousness might be a better descriptor. So asking about anxiety and asking about that just straightforward is quick, it's simple, it is helpful, it'll help you. Because if you have a patient with palpitations, or if you have a patient with unexplained lower back pain, or if you have a patient with headaches, tension headaches, right? And they're just not going away. Asking about anxiety is going to be helpful because then you can address it. And there's different ways to address it, and we'll talk about that. And then mood. Let's talk about mood for a second. So mood is the second part of AMPS right here. And there are two subcomponents to mood. The first subcomponent is depression. The second subcomponent is what? Mania, exactly. So mania or hypomania. And so those are the two subcomponents. It is important when screening for depression to also include a couple questions about mania or hypomania. In my opinion, one of the most difficult things in psychiatry is to figure out if someone's had a manic episode in the past. That is hard. That's hard for me. But it's important. It's important because let's say someone comes in your office and they're sitting there and they're depressed, they're sad, they're tearful, they're anhedonic. Let's say that happens, okay? And then they're, you know they're depressed and they have headaches, they have unexplained back pain, and all this stuff is happening. If you give them an antidepressant without asking them about their past, again, that can be a problem. We talked about that earlier. So we want to figure out if someone's had one or more discrete, episodic, manic or hypomanic episodes in the past. Again, hard to do. How do you guys do that? How do you figure out if someone's had a manic or hypomanic episode in the past? What kind of questions might you ask? You don't. Who said that? I love it. Great answer. I don't. Right, that's good. It's not, though, but it's all right. We're here. We're doing this together. Thank you for being here, by the way. So most don't do that. For those of you who do, what questions do you ask? So financial. Do you have financial problems? A lot of people have financial problems, right? I had a medical student once that said, here's the thing. I'm going to ask my patient some questions to see if they've had a manic episode. I said, okay, go ahead. I'm going to listen in. And they said, okay, this is a third-year medical student, and she's great. She's very nice. But she comes in and she sits down and she goes, okay, I'm going to ask you some questions because it seems you're really depressed, but I'm going to ask you some questions about the past. In the past, have you ever been in a situation where you really, really like to shop a lot? Has that ever been the case? Patient's like, yeah. And then the student goes, well, okay, have you ever been in a situation where you really enjoyed sex, like a lot? Guess what the patient said? So we didn't really get any new information here, right? The patient likes sex and shopping. Probably AC/DC, I don't know. So, but the thing here is we want to be quick, we want to be targeted, we want to get the data so we can make the diagnosis. Number one, and number two, affect change with the right treatment. That's it, right? And so here's some pointers on this two subcomponents with depression and mania or hypomania. For depression, two questions you can ask. Number one is, have you been sad or depressed in the last couple weeks? Okay? Have you been sad or depressed in the last couple weeks? And you're looking for a current depression, right? A current depressive episode. And then the second question is related to anhedonia, right? The standard of care is saying, hey, what do you like to do for fun? And have you been doing it? It's a two-part question, right? And so those are your two screener questions. We'll see a slide up here in a second for the mnemonic SIGI caps. Who uses SIGI caps? Yeah, don't use SIGI caps. Too many questions, right? We don't have time for SIGI caps, and we'll talk about what that is in a second. Those are your two screeners, right? And I know you know that those are the two questions in the PHQ-2 and the PHQ-9. Dr. Kroenke and others put together, about 25 years ago. Now, if someone is depressed in front of you and you're like, okay, I really want to give them an antidepressant, you got to ask about mania or hypomania. So what are those questions that you can figure out? You don't want, asking about shopping and sex, it probably don't work that well. So here are the two questions that we recommend that you ask. Number one, this is the first question. You guys excited? This is it. It's happening right now. It's going to happen. It's right here. Okay, so this is the first question is, have you ever felt the complete opposite of depressed? Abnormally happy, and then this is the important part, where friends and family have been freaked out, worried, told you to go to the doctor because you talk too fast, you think too fast, right? Got too much energy. That's the key part, getting the collateral history without having the collateral historian present. I do the same with CHF and COPD and whatever else it is, Has your family kind of come up to you and said, hey, you should lay off the beer, or you should lay off the dressing, the turkeys, whatever you're eating that's not good for you? Oh yeah, I've been hearing that lately, right? Then you have a clue that the family is concerned. And so that's a great way to get that collateral history. That's the first question. Second question is, have you ever been in a situation where you have a lot of energy, so much energy that because of that energy, you don't need to sleep for days and days at a time? You're tying in energy with lack of sleep. If you just say, hey, have you ever been in a situation where you don't sleep really well? Right, that's not going to work. So you want to tie in. Now, if they say, yeah, man, yes, the answer is yes. And you say, okay, when is the last time that happened? So that's your next question. Take me back to that time. Oh, it was two Halloweens ago, right? And let them describe to you what that episode was. Let them tell you so then you can figure out, hey, this was a manic or hypomanic episode. If it was, their diagnosis can never be major depressive disorder ever again. Their diagnosis is now bipolar spectrum disorder, currently depressed, for which the treatment's different. Questions on that? It's kind of it's a big point. I want to make sure, does it make sense? Sort of, kind of? Got it? Okay, I see a lot of thumbs up here. Great. So AMPS. So we have the A, we have the mood. Let's talk about psychosis. Now, you're probably not going to see a whole lot of psychosis in what you do. But if you do, there's a lot of reasons for it. And I want to point out the fact that most psychosis is not necessarily schizophrenia. When I trained in Chicago, this was back in the 1960s, right? I'm just kidding. I saw you're like, what, 1960s? It's 1950s. And so, but when I saw someone come into the emergency room, like at Cook County, for example, they would come in and they would have schizophrenia. And maybe 1 out of 10 would have, would be psychotic due to cocaine. Now when I'm in the emergency room and I'm working on the weekends, what's the number one cause of psychosis now? It's meth. Yeah, it's meth in most parts of the country. And so all psychosis is not just from schizophrenia, so that's an important thing to keep in mind. There are two things I want you to keep in mind when asking questions about psychosis, because this is an important component of AMPS, it's an important component of what you want to ask. First question, hallucinations. Okay? When you're asking about hallucinations, I would recommend, if possible, staying away from, do you hear things that aren't there? Why do we stay away from that question? Because they'll be like, what? You don't believe me? That's what they're going to do. So what's another way you can ask about hallucinations? What's another way? Have you heard things that other people haven't heard? Have you seen things that other people don't see? By the way, visual hallucinations are pretty rare in primary psychotic disorders. But that's a great way to ask it, right? It's quick, it's simple, boom. Now, delusions are fixed false beliefs, delusions. It's important to ask about delusions as well. And so there are different types of delusions. The most common type of delusion that we see in primary care is, what is it? Someone's watching me delusion. That's what it's called. So paranoid delusions, right? And so here's how you can ask about paranoid delusions. Do you have thoughts people are trying to get you, follow you, hurt you, or spy on you? There you go, right? And so that's a quick and easy way to ask about psychosis. Now, there's a lot of other questions you can ask. And if you're a psychiatrist with an hour and a couch in your office, you have time to do that. But you guys, this is kind of a quick overview here. And those are the questions for psychosis. Now, you're going to learn a lot more about substance use disorders. But I want to point out a couple things. Alcohol. Alcohol is the most commonly used substance in this country, and it's the most commonly misused substance in this country, right? So does that make sense? So people use alcohol, and they use it appropriately. It's fine. And then, of course, it can be detrimental to their health. So what I recommend is not to ask patients, hey, do you use alcohol? But to make the assumption, right? How much alcohol do you drink a day? And you're starting with that premise. You're not going to say, how much alcohol do you misuse a day? How much alcohol do you use a day? Don't do the same with heroin. You don't want to do that, right? And if you do, don't say you learned it here, right? You'll get in big trouble. But how much alcohol do you use a day? And because if you say, hey, do you use alcohol? Yeah. How much do you use? It depends on the day. I mean, then you have a bunch of questions lined up. How much alcohol do you use a day? What's the best way to ask about drugs? What's that? So when is the last time you used drugs? You could do that. Again, you didn't learn it here. No. But that's one option. What else? How do you guys ask? Let me come over here. How you guys doing? Good morning. How do you ask about drug use? When is the last time you used? So when is the last time you used drugs? Okay. Yeah. Do you use any non-prescribed substances? Okay. I'm interested to hear how you, what about over here? What's that? Have you ever tried? Okay. So there's a lot of ways you can ask. You know, a lot of folks say, do you use recreational substances? Does anyone ask that? Recreational? I don't know what that means exactly. Like, do you use at Disneyland? And I don't know, Splash Mountain, hey, I'm going to use drugs. But I don't know. And then illicit or illegal. Well, I used to do that. And they're like, are you FBI? I was like, no. No. I gave that up a long time ago. But here's the thing. I would just be clear, concise, keep it simple. Do you use any cocaine, heroin, acid, speed, ecstasy, marijuana, whatever's in your region, basically. We're seeing a lot of synthetic marijuana in Orange County, unfortunately, in junior high school kids, which is horrible. But basically, create your own list, and then that's it. Just be clear, right? And I just to be really clear. But does that make sense? Do you use any cocaine, heroin, acid, speed, ecstasy, marijuana? I'm sure I missed some. Justine and Steve can tell me later. I'm sure I've missed some there. But that's my mantra. And so that's substance use. That's AMPS, right? And so that's a quick, non-comprehensive, but certainly very relevant approach in the primary care setting. And so, please consider using this. This lady's anxious here. We're going to talk a little bit about anxiety disorders a little bit later, but this is kind of just a quick overview on anxiety disorders. Again, the question you want to ask about anxiety is very simple. Hey, are you anxious or nervous? That's it. That's the question. And if someone says to you, yeah, I'm anxious or nervous, I think the next question, instead of going through a checklist, is, can you do me a favor? Can you tell me what your anxiety is like on a Monday, a Tuesday, a Wednesday, a Thursday? Just tell me what your anxiety is like. Can you tell me? And let them tell you. It'll take a minute. And that minute's important because based on that, you can figure out, oh my gosh, this sounds like panic disorder. This sounds like generalized anxiety disorder. This is definitely PTSD. And the treatments are different. They're different with those disorders. So just being really clear and asking about anxiety. Now, I put this slide up here because it's kind of important. This doc is telling this poor patient, looks like it could be depression. And the reason I put this up here is, and I'll tell you by asking the group a couple questions. And these are simple. So these are really, so what is the cause pathophysiologically for schizophrenia? Very straightforward question. The part of the brain that it affects. Let's do this one. Bipolar disorder. The part of the brain that's affected. Okay, let's do this. So depression. So why do you not know the answers? Because you're answering everything else. Say that again. We don't know, for the love of God. We don't know. Now, this is important. If someone comes in with a sodium level of 118, we can look at two things. We can look at their fluid status, and we can look at their serum osmolality, and we could use those two pieces of information to figure out what is causing their hyponatremia. If someone comes in with strep throat or a bad sore throat, and they have exudate and erythema and no cough and lymphadenopathy, you could make a clinical diagnosis, but you could pretty much know it for sure too by doing a strep test, right? If someone comes in with dysuria, you kind of know, right? All right. Someone comes in with depression. Someone comes in with anxiety. Someone comes in with psychosis. Guess what? No clue. We don't know the pathology behind it. This is critically important. Bless you. This is critically important. Because in the world of medicine, for which psychiatry is a key part, we're stuck. Think about this. If we don't know the pathology, how are we going to really know the best treatments? That's why when you give someone an antidepressant, there's a 50-50 chance an antidepressant is going to work. That's why when you give someone an antipsychotic and they have schizophrenia, there's not a cure. Most patients are just not going to get better, right, with that treatment and that condition. So I want you to keep this in mind for this reason. It is oftentimes a challenge to be a primary care psychiatrist. It's oftentimes perplexing, draining. Does anyone ever feel drained at work, by the way? Anyone feel drained at work? No hands go up? Oh, okay, all right. So, I want that. This is important. This is important, and I think one of the reasons is there are not cures. There are not cures for what we're doing. If someone comes in with hyponatremia, using that example, you give them sodium, and you figure out why they're hyponatremic, right? But when it comes to psychiatric disorders, and again, I think it's a barrier, but it's also for me a blessing. That's why I'm a psychiatrist. I still think we can make a positive difference. I know we can make a positive difference with helping co-manage with your patients. Maybe not a cure, right? Now keep in mind, major depressive disorder, major depressive episodes get better on their own. They get better on their own, usually within a year to year and a half, and they'll kind of go away. So that's why I put this up here. I think it's an important point to keep in mind. This is a mnemonic that I talked about earlier, the Siggy caps, that's Siggy right there. He looks depressed. And so basically, this is a mnemonic that sometimes medical students will use, and they'll go through that checklist, but we don't have time for that. So the two screener questions that we can ask about for depression are what, as a reminder? The first question is what? Have you been depressed for a couple weeks? What's the second question? Louder? No. Energy. No, so you're basically, so it's anhedonia. So what do you like to do for fun, and have you been doing it, right? Those are the first two questions for depression. Then the two questions for mania, to see if someone's had a manic or hypomanic episode in the past, are what? What's the first one? Have family and friends been worried or concerned that you're too happy, too excited, And the second question for mania is what? You're tying in insomnia with a lot of energy, right? You're tying those two together. Great. So you just want to be mindful of that. And now, check this out. These are the criteria, the DSM-5 TR criteria for a manic episode. That's a lot to ask a patient, right? I mean, seriously. I mean, look at that. I mean, could you imagine like a patient coming in with, early heart failure, some diabetes, osteoarthritis of the knee, and hypothyroidism, and then you got to ask these questions because they're depressed. You got to make sure you ask about mania. This is too much. So, hey, have you been grandiose? How's your sleep? Are you more talkative, racing thoughts, distractibility, and all that stuff? Now, it's always important to get the collateral. Let me give you an example. I had a patient years ago who was on Depakote, lithium, and Zyprexa. And the chart said bipolar disorder. So I said, hey, good to see you. And we were talking. First visit. And I go, so it looks like you have bipolar disorder. No, I do not have bipolar disorder. I said, okay. It looks like you're being treated for bipolar disorder. I don't have bipolar disorder. I'm fine, doc. I said, okay. So I asked him, this was a long time ago. I asked him, have you ever been on top of the world? He's like, yeah, but no, I asked some of these vague questions I asked him, and it wasn't clear to me. And then I asked him, I said, have you ever been in a situation where you've been the complete opposite of depressed, abnormally happy, where friends and family were worried about you because you were too happy or too excited at one point? And then he said, well, my brother, he gets in my business. That's what he said to me. And I said, okay, I'm going to go with that. So I said, well, what did your brother say? Well, my brother, he got in my business, and he got, he thought I was manic, and then I got in the hospital because he thought I was manic, but I really wasn't, doc. And I said, okay. So I said, well, here's what I want you to do. Take me back to that time when your brother thought all of this. What was happening? And this is what he told me. He says, I'm a political guy. I like politics. And I really wanted this presidential candidate to win the election, so I joined his team. And I said, oh, that's great. And he goes, well, one of the things I wanted to do is make sure the candidate got from state to state. I'm really like travel arranging. I said, that's cool. And he goes, yeah. I go, well, why did your brother get upset? He goes, well, technically, I wanted to help with the flying of the plane. Technically, I'm not a pilot per se, and my brother is in the Secret Service, and so basically he got arrested on the tarmac, and he was trying to get on the plane to help out, with the flying of the plane from A to B. So, but then I was able to understand, that's a manic episode, and I could really understand, right? So taking the patient back to that time, when did that happen? Can you tell me? Right? Oh, that happened 3 Christmases ago. Let them tell you what happened. Does that make sense? And it'll take a minute or two. But once you get that story from the patient's brother, then you know what the diagnosis is, which is really going to be helpful for you. Okay. Keep in mind that there are some episodes that have a little bit of depression and they have a little bit of mania. They kind of have a little bit of this and a little bit of that. We call these kind of mixed episodes. So an example would be someone who's depressed, someone who's sad, maybe nihilistic, and they're down, but at the same time, they have fast thoughts. They're thinking, and they're moving fast, right? And that's indicative of the patient we saw earlier, right? The 26-year-old case that we saw, that we briefly described. Now, that's complicated. I would refer to a psychiatrist. Patients like that are at high risk for suicide attempts, and also treatment refractory condition. So if you see a patient who's got both of those things going on right in front of you, get help. I would refer if you can and make it a priority. And that's folks who have mixed episodes. So we talked about psychosis and earlier, and we want to keep this. Do you guys see this? So he's got a bird on his shoulder, and he says, I think I can get rid of those voices in your head. And the psychiatrist, notice there's a couch, so this is not a primary care setting, right? Psychiatrists, they're awesome, but they have the couches, and then they have the mood music and the little fountains, and it's really beautiful. So, there you go. But psychosis, remember, this is important. So remember, with psychosis, you want to ask about hallucinations and delusions, right? And that's a quick 30-second questions that you can ask to figure out what's going on. Remember that most psychosis is not necessarily going to be schizophrenia. It could be, but it could also be substance-induced as well, right? And then the other thing I want to mention very briefly is, and my colleagues who are much smarter than me when it comes to this kind of stuff, we'll talk more about this, but CAGE questions. Who's familiar with CAGE? Okay, you guys are all. So CAGE is a series of 4 questions that you can ask to figure out the likelihood as a screening to figure out if someone has a problem with substance use, like alcohol, let's say, for example, right? Now, here's the thing. I'm going to recommend not using CAGE, but instead doing something different that's quicker. What's the purpose of the CAGE questions? To see if they've got a problem with the thing, the alcohol, whatever it is, right? That's the purpose. What's a quicker way to figure out if they have a problem other than asking 4 CAGE questions? What's the quickest way? Ask them directly. Now, it may not work all the time. It may not work all the time. But I would just say, hey, do you think you got a problem with alcohol? Yeah. Okay. Boom. Right? Then you can talk to the patient about treatment, next step. You have the diagnosis. Now, you can ask other questions as well, blackouts, DUIs, whatever. But the bottom line is I wouldn't jump to the CAGE right away. Ask the patient, hey, what do you think? Are you struggling a little bit with this? Is this a problem for you? They're like, yeah, it is. You don't need to ask CAGE. And you don't need to do the audit C, which we'll learn about later. Does that make sense? Just be direct, right? And I had a patient the other day. I was like, hey, do you think you got a problem with alcohol? He's like, no. And then he texted me. I gave him my phone number. I don't usually do that. But he texted me, and you know what he did? He says, Dr. McCarron, do you have a second? I said, yeah, I called him back. It was like half an hour. He goes, I didn't tell you the truth. I have a serious problem with alcohol. And so he didn't want to tell me at that point, which is totally cool. But then he eventually told me, right? Because we were able to build that rapport. And now he's in a rehab facility. This just happened a couple days ago. So that's a good way to ask about this. I don't know what this varmint is, by the way. My wife showed this to me, and I was like, so let me ask you, so all of our patients are wonderful people. There's no question about that. But has anyone struggled with a patient in terms of interpersonal kind of weirdness? Nobody? One person? No, I'm just kidding. Who has not struggled with that? All right. Who struggled with it? All right. So that's called normal, right? And so here's the deal. You're going to have folks who come to you and they may have just personality disorders. And we call that, per DSM, a personality disorder is something that starts pre-adolescence and then it grows and it gains momentum. It gains momentum. And so that's what a personality disorder is. And then it flourishes in the 20s and the 30s. And so if you have someone, and I'll use the example, borderline personality disorder, and borderline personality disorder, very simply, is a condition where the patient has a poor sense of self, right? And there's fear of abandonment. Abandonment. My friend's going to leave me. My parents are going to leave me. My spouse, no one's with me. And oftentimes, a high level of instability when it comes to their life. A high level of instability when it comes to their relationships. Instability is the operative word here. And that's borderline personality disorder. So what I've learned over the years, and also with my own experience, is this. It's hard doing the work that we do. It's not easy. It's not easy. And sometimes when we're working with patients who might be mean to us, derogatory, right? It's hard. That can be challenging. I remember right out of residency, my colleague Jay Hahn and I ran a busy crisis stabilization unit in Sacramento. It was the only one in Sacramento. And we'd see like 50 patients a day. We had 4 seclusion and restraint rooms. I think it was 3 or 4, something along those lines. Forget now. But it was always busy. And every single day, every day, there would be at least a handful of patients coming in just screaming at one of us, threatening our family. I'm going to go to your house. And these are folks who were tased out in the field like 4 times. And they'd come in, and Jeremy, you know what I'm talking about. And I was like, this sucks. This is hard, right? And so So over the years, really tried to figure out a way. And in primary care, you see it too. You see the front office staff, you may not see this, but the front office staff struggle too. They struggle a lot with patients who are struggling, and they don't know how to deal with it. So these are some things, these are some tools that I think are helpful for us as primary care providers. Helpful for us to help the patient, but also help ourselves. So at the end of the day, when we're driving home, we don't feel all the tension right here. We feel okay, right? And so let's go through this. So I'm using the mnemonic. I like mnemonics if you haven't noticed. And so E equals MC cubed. We created our own equation. Squared is okay. It's okay. It works mathematically, but cubed is better. So what do you do when you have these? First of all, so you guys can relate what I'm talking about? Yes? Have you ever come in and you look at your list and you're like, oh, my 11 o'clock, oh, good Lord. And then something happens right around this area, and then some acid comes up here. And it may come all the way out later, who knows. But and so let's talk about how to do that, how to deal with that. Let's do this. And so the E in E equals MC cubed is empathy, not sympathy. Empathy, becoming the patient. What's it like? What's it like to be them? What's it like to be someone who really is disliked when they go to the supermarket or the gas station or anywhere? What's that like? What's it like to go, to the front office, to the doctor's office, and see the staff roll their eyes, right? Or go, oh, God, right? I mean, they know that. They feel it all day long. What's it like to not have a stable family relationship? What's it like to not have a core group of friends? What is that like? For the love of God, that's bad. So if you know that, or for me, what's it like to be tased 4 times by the police and then come in with a spit mask on, right? What is that like? And so to connect with that patient does 2 things. The first thing it does is it helps your relationship with the patient. But the second thing it does is it helps you, because when you're dealing with patients who have personality disorders, you'll tend to not personalize it when they say things to you, right? You're not going to personalize it because you know it's not about you. It happens when they go to Del Taco and they're, screaming at the person over the counter of Del Taco or Taco Bell, whichever you prefer, And so it's not just you. And so you're not personalizing it. If you empathize with your patients in this capacity, you're really going to understand that they're struggling. And what you're seeing is them struggling. It's not them fighting you or going against you or you're a bad doctor. Listen to me. Whatever it is, it's more I'm struggling. And they can't really word it that way. So it's really a maladaptive approach to what they're dealing with on a chronic daily basis. And so empathizing with your patient not only helps you and your patient, but it helps you. At the end of the day, I started doing this in the crisis unit. At the end of the day, I wasn't as tense here, and I felt okay. And I realized that my patients really didn't want to kill my family, when they were psychotic. I mean, that sounds weird, but they didn't. They were just in a horrible place. Horrible place. Have any of you been in a spit mask before? It's very uncomfortable. I tried it once. Jeremy, I tried it one time just to see what it was like for like a minute. But it's horrible, right? And to be in seclusion and restraints. But for many of you, these patients will come in and they're struggling, they're suffering, and that's why they're, quote, acting out, right? The other thing is manage, not cure. We talked about this. In the world of psychiatry, the reality is this. This is our reality. We don't know the pathophysiology. Because we don't know that, we oftentimes don't have the best treatment. I would argue that we don't have the treatment. We're here to work as a team with our patient, with them, to try and figure out how we can manage these symptoms. To me, that's a blessing, because in the world of psychiatry and primary care, we can help decrease those symptoms. We can help decrease the angst. Maybe not with a pill that's going to work. Maybe not, right? Because we don't have the pathophysiology, but we can work with our patients, supportive psychotherapy and other things that we can do to help them manage these symptoms. Countertransference. Be aware of your own feelings. I know you're busy, and you're like, I don't have time for feelings, right? But if you're aware of your own feelings, and if you're in the fellowship, we're going to talk a lot about this, be aware of your own anxiety with the patient. Be aware of your own fear with the patient. Be aware if you really like a patient a lot, right? I mean, maybe to the point where it's not healthy. Be aware with that. Be aware of it. Don't ignore it. Embrace it. It's telling you something. Feel what you're feeling with these patients, and that's important. Comorbidity. When you have someone with a lot of disruption in the front office or they're not treating you well, make sure you do an AMPS. Make sure you do a quick AMPS. Check for anxiety, check for mood, check for psychosis, check for any substance issues. And you want to check for that because those are often comorbid, highly comorbid with personality disorders. And then last is consistency. And this is important. You want to be consistent with your relationship with a patient, for example, who has borderline personality disorder. You don't want to say one thing and then do another thing the next time. And here's why. Because you're modeling healthy relationship. Isn't that interesting? You're modeling a healthy, good relationship. Because a lot of them may not have that. They're living in dysfunction. And so you're modeling that. And so being consistent shows them, I think, that you're invested. Being consistent shows them that you care in a different kind of way. Okay, risk for suicide. I'm going to be really quick on this. About half of those who kill themselves see you within 1 month of doing so. Right? And most of the time, they're not coming in saying, I have suicidal ideation and intent. They're coming in and saying this, I have really bad back pain, or I have really bad headaches, doc, or I really can't sleep, I'm up all night. And so screen, right? Make sure to screen. If you notice that there might be, a blunted affect, there might be something else going on, make sure to ask, right? And also document. About 25 to 50% of suicides end up in litigation of some type. So from a medical practice standpoint, you also want to make sure you're documenting if you're asking these questions. Ask about firearms. So about 70% of men who do commit suicide do so by use of guns, and about 50% of women as well. These are some of the suicide risk factors. I put up this road sign here. I don't know if you can see it. It says, caution, water on road during rain. Interesting. So this is true. I put that up here because it's intuitive. I think these risk factors just make perfect sense. Like, we know someone's risk for suicide goes up if they're having suicidal ideation, right? It just makes sense. We probably know that it goes up if they're using if they have guns. Command hallucinations are like auditory hallucinations, commanding someone to do something. We often see this in schizophrenia. So kill yourself, kill yourself, kill yourself. You're not good. You're not good. Kill yourself. Something like that. And that's horrible. I mean, we see that in primary psychosis. Anxiety is the number one cause, or the number one affiliate factor with suicide in those who are admitted to hospitals, whether it be a psychiatric hospital or general medical or med-surg. History of previous attempt increases the risk, as well as family history or recent exposure, media exposure, for example, as well, and then substance use disorders is also something that we want to consider as well. I have about a minute left, and I'd like to use that to thank all of you for being here and for listening. And I also am appreciative of your feedback and your thoughts, and really looking forward to learning together with you. But I would like to take some questions. Yes? Yeah, so the question is, if someone's at high risk for suicide, great question, and they have firearms, what do you do? And here's the answer to your question. It depends on the state, first of all. Second of all, if someone's at moderate or high risk of suicide, don't just send them home, because you're going to document in your note moderate or high risk of suicide, so they need to not go home. Okay, so that's the first thing, is maintenance of safety, and it's going to be depending on the state. It's going to look differently. California, we would, if the patient says no, I don't want to be held, then they would be on an involuntary hold up to 3 days, and that's maintenance of safety, and that's what our due diligence. We would need to make sure that if we assess the patient to be at moderate or high risk, they don't go home from your office. And in that case, if they are in an involuntary hold in California, then they're not eligible to get more guns, and they should not have guns at their house.